I think we're up.
All right.
So you may start now.
Nice
Ready
to
to
see
go.
everybody again. Thank you for joining us here on Facebook Live for another little bit of a guide to greater living, we hope. I'm Don Scott.
I'm Mary Beth Marsden, and today we're going to be talking about something really, really interesting, and I'm sure that's changed over a lot of years, and bigger changes yet to come, and that is genetic testing. Not only genetic testing, but all kinds of genetics and genetic counseling and who it affects. And we're not just talking about prenatal testing, we're talking about postnatal, we're talking about teenagers who also get tested genetically, and what it all means. And we have two great guests from GBMC, Dr. Natalie Blagowidow and Amy Kimball, who's a genetic counselor. Thank you both so much for being with us, but we should mention that Dr. Blagowidow is the Prenatal Diagnostics Center at GBMC. She's the director and also the director for the Harvey Institute for Human Genetics. And gosh, I'm so, we're fixing a little microphone here. Is it not on?
No, it's not.
Okay, well, good thing we haven't asked the question yet. This will give you time to think. I'll tell you what, I'm going to throw a question out there. And both Don and I were talking about genetics and what we remember from our experiences. And, you know, both being in the news, I can tell you we've had so many stories over the years about research and what's been discovered and the human genome, and it's really mind-blowing.
Right, it is. And now for prenatal diagnostics, which Amy and I are both involved in, the amount of testing that we can offer expectant parents has just exploded over the years compared to when I started in the field. So we offer testing for both testing the baby and looking with ultrasound and with various blood tests, looking for different disorders, chromosomal abnormalities, looking for hereditary conditions. But in addition to those tests, which we can go into a little bit more, we can also test the parents themselves.
So I'll just add that a while back, it used to be those who were deemed high risk, whether family history, whether they were a parent over 35, would be sent for testing and counseling. But now we have these genetic tests that are offered to just everyone who's pregnant, whether they're 20, 30, 40, things like carrier screening to see if they might carry a genetic condition like cystic fibrosis, but the list of things we can test for are into the 200s.
And do you tell the parents from the beginning, would the parents to be, that they're being tested, or is it just part of the normal procedure now?
Absolutely. The patient should be informed. They should be able to make choices. They should be able to decide, is this information we want? Would we want to know this information now, or is it just going to overwhelm us? Is it going to cause us anxiety during the pregnancy? And thankfully, most of the time, we're providing reassurance, but it's absolutely a discussion with that family, that couple, so that they can make informed choices.
Because I remember, again, in our past, 30 years ago, something like that, when they went beyond ultrasound, you kind of went, why? You know, why? Is there something wrong? Was something wrong with the ultrasound? Is that where stuff shows up in the beginning?
Ultrasound has also come a long way, and it certainly...
It sure has.
Right.
I mean, you see like the whole kid, you know.
Exactly. I think years ago, I know when I was pregnant and had an ultrasound, and, you know, and then I'd show people the picture, and they would go, "Oh, is that the leg or that's the face?" I would just agree with everybody, but really, it was a fuzzy little picture. And nowadays, the details we can see, we can look and see a 4-chamber heart at 11 weeks of pregnancy. We can see amazing things, but you're right that will also identify maybe something that early on that will be concerning and lead to additional testing. But there's testing we can do without ultrasound just to research and looking for problems in the pregnancy.
I think we should mention too that we have a studio audience here with us, and I'm looking out and I'm thinking that most of you have probably some grown children, right? Maybe even grandchildren. So this is really valuable information for your generations to come, and also for all the people who are watching us right now on Facebook. We have all kinds of ages watching, people who are thinking about having children, and this is something to think about now too. No matter what your age, if you're thinking about having children, these are the kinds of things that are running through your head. And I have to say, when you first start broaching that topic, it can be scary.
Yeah. I think it's very overwhelming for families, the amount of tests that they can do, understanding what they mean. I would urge a family who's thinking about start a couple thinking about starting a family to start the dialogue with their OB even before they conceive. What kind of testing can I do now? What kind of reassurance can I gain even before we start trying to get pregnant?
I know everybody today arranges things, including when they're going to give birth to their child and things. But so
Yeah, best of luck with that, right?
it seems to work in a couple of cases I know of, but not personally. But let's say someone is thinking about having a child. Should they immediately come to the genetic center and begin testing?
Really, they don't need to see us primarily, but go to, as Amy said, to your own obstetrician gynecologist. They can suggest the tests that there are limited tests that are recommended by the American College of Obstetrics and Gynecology that all people considering getting pregnant should do, screening for very common disorders, and also to get your health to the best shape as it can be. If you're diabetic, you want to make sure your glucose levels are normal. If you're on medication, do you need to be on those 2 medications because you have a seizure problem? Maybe you can be on 1 medication, that sort of thing. So that your general doctor can do. But then once testing becomes, once a test may be abnormal, or if in talking with your doctor there's a family history that suggests that there's a problem, that's the time to come and see us already, even before pregnancy. And certainly I know Amy's definitely seen a number of couples preconception.
Right, so sometimes families will come because they want to have what we call carrier testing, where we send a saliva sample or a blood sample to check a number of genes that are recessive, where you can be a carrier and have no idea because you're perfectly healthy, but if both parents are carriers, they could have a child with that condition. And I mentioned cystic fibrosis again because it's just one of the common ones, but the list goes on. And this is information that they can obtain prior to even conceiving, and we can say, you're not a carrier for any of the conditions on the panel, your risk is very, very low, or indeed you are at risk for having a pregnancy with such and such condition, and then go from there.
I'm going to ask a question. We're going to get very specific about testing and exactly what it all means and what specific tests there are now. But just on the broader sense, do you have any idea percentage-wise how many expectant parents or planning to be parents actually do get tested? Because it is my sense that the majority aren't thinking in those terms unless there's some kind of red flag in their family they already know about, or their age has become a factor. Would you agree? Or is it becoming more commonplace, I guess is my question.
I think it's becoming more commonplace. I think between social media and whatnot, I think it's becoming commonplace. I think we see a very biased population because everyone who makes it to our office is motivated to do testing. So there's plenty of families who never even get to our office, or they do the screening through their OB and everything is reassuring and they don't end up coming to see us.
I hear you saying screening and testing. Mm-hmm. Those aren't the same thing?
So
So no, screening and testing is not exactly the same, although I think Amy could explain it very well. So screening is you're just looking, is there an increased risk for this problem? So one of the tests that we've done for many years is alpha-fetoprotein, and that's still recommended around 16 weeks of pregnancy. That's a screening test. If that blood level is high in the mother, higher risk for the baby to have a birth defect such as spina bifida. But it's a screening test. It certainly doesn't mean the baby has spina bifida. Then we can do a more diagnostic test, which used to be doing an amniocentesis and looking at the amniotic fluid for that alpha-fetoprotein and other biochemicals. But just your point from earlier, that ultrasound from many years ago, nowadays I feel very confident that we can do a detailed ultrasound and to really evaluate the spine.
And you don't have to do an amnio?
Not anymore for spina bifida.
Wow.
So yeah, the imaging has just gotten terrific.
I was witness to an amniocentesis, and it was fascinating for the man to watch.
Yeah, my husband almost fainted.
Yeah.
And that's a diagnostic test. That's the definite answer where you'll see those chromosomes, as opposed to doing a blood test, which will just give you an idea.
And apparently we have an audience question.
Yeah, we actually have 2 audience questions. Here's the first one. Are the over-the-counter DNA tests like 23andMe and Ancestry worth the money? What do they tell us, and are they accurate?
Do you want to do that one?
I haven't heavily explored 23andMe, but I think the limitation is interpreting those results. So who's explaining those results to the person who's doing it? When they get those results, are they really going to understand what that means for their health? If a family comes to me and they said, oh, I did 23andMe and I'm a carrier for such and such condition, I usually repeat it at a clinical lab that we have good experience with, and I don't really even pay attention to their 23andMe results. So I think it's something that I think you have to think about, will you be able to understand what your results mean?
Yeah, and I have to agree with Amy. I'll agree and disagree. I'll disagree a little bit. I do think they're fairly reliable, and actually 23andMe has gotten so many people to send them blood samples that they are very involved now in research and offering those blood samples for research. So that is a good positive sort of spin from them. But I've definitely had friends contact me. They couldn't understand the report. Things were unearthed that they had no interest in looking for, and it gets very confusing. So I don't really recommend it just to send off just out of curiosity. And then the heritability, looking at your ethnic background, it's fairly reliable, and that's just for fun. So you can certainly do it. It's not a problem.
In fact, I thought that DNA test was just for fun.
And that from that level, it's fine. Yeah.
Would you be worried? I'm just wondering if you got a false positive. I guess wouldn't be as worrisome as a false negative. Would you be worried that something serious wouldn't come out in one of these tests and someone would just move on, maybe making family planning a priority with just using this test and then have a surprise down the road? Is that too far flung?
Yeah, no, we both agree.
Yeah. I think I'll just use a scenario. If one partner knows they're a carrier for cystic fibrosis and the other one had testing through 23andMe and it was negative and they felt reassured, that might be completely legitimate, but what is the detection rate of carriers for the 23andMe test? Do they catch every carrier? Do they miss 10% of carriers? So does that couple understand that this doesn't rule out cystic fibrosis? I think the other side of it is if it comes back positive for cardiovascular disease risk, it's understanding, well, how much does that increase your risk? Does it increase it dramatically? Does it increase it by a small percentage? And so understanding what a positive really means.
Okay, I think we had another audience question.
Yes, this question is genetic testing generally covered by insurance?
We thought that question might come up, and Amy got assigned to answer the question.
So it's variable. I think that most insurance companies have policies for genetic testing. I think that when we use this term genetic testing, there are so many things that fall in that category. There could be testing for Down syndrome during pregnancy. There could be carrier screen that we've talked about. There could be testing for cancer genes. And every insurance company has different criteria for what they will pay for in certain circumstances. And oftentimes, as a genetic counselor, that's part of our job, is helping navigate that for the family. I think sometimes things are covered, but families have large deductibles, and genetic testing as a whole tends to be very expensive. So there's no straight answer for that. But as a whole, I think insurance companies are doing a very good job.
Can I ask a stickier question to go with that a little bit? So when you talk about insurance, there's all kinds of concerns with privacy and concerns about pre-existing conditions and how that will be interpreted by insurance companies. Knowledge that comes from genetic testing, that now what do you do with that knowledge? Do you want an insurance company to even know about it? And those kinds of questions, I'm sure, are pretty prominent. Maybe not in prenatal, but in other kinds of testing.
So it's actually a question that we don't really address often in prenatal, but I know our genetic counselor who works with families in the cancer realm, that's a question that comes up all the time because families might be thinking about life insurance and such like that. There are laws in place that are supposed to protect people from bias based on genetic testing.
But just what Amy said. So yes, you're protected medically. Like you can still get health insurance if you're found to have a genetic condition currently. The law protects you from that, but it does not protect you from the insurance industry saying, oh, but look, you have this genetic condition, we're not going to insure you. So there is that limitation, and that's like life insurance, not health insurance.
Okay, so far we've talked about blood tests, we've talked about ultrasound and amniocentesis, which you used to do. What follows ultrasound now if somebody needs further testing? What kind of tests are we talking about?
Yeah, no, amniocentesis hasn't completely gone away, but I guess Klinefelter sampling, where you can do testing between 10 and 12 weeks of pregnancy, it's been around for a while now, so you can have earlier invasive testing if you're going to do that. But nowadays, we don't do too much of amnio or Klinefelter sampling. When we're screening for chromosome abnormalities, we're doing something called NIPS, which is a blood test looking at little fragments of DNA breaking off from the placenta, getting into the mother's bloodstream, and finding these just a few fragments circulating around. And if there's just a few more of a particular chromosome, that can be detected. So it's amazing technology.
So I remember a time when genetic testing was rather limited and you could only really test for a handful of things. Could you tick down some of the things that you actually can test for, and are they definitive? So if you said certain chromosomes show up or certain abnormalities show up, is that a percentage that will be passed on to the newborn, or is it a definitive? Is it a definitive? Yes, this is what it is.
Right. So with the invasive test of Klinefelter sampling or amnio, it's a definitive. We can get a definitive answer. With this blood test, it really varies how accurate it is. Detection for Down syndrome is over 99%. Detection for actually diseases caused by smaller pieces of chromosome, 5-10%. What that means is somebody who would get a positive result from that blood test, only 1 out of the 10 people will really have a baby with that problem. So it's not a perfect test.
Back in my experience with amniocentesis, there was a great emphasis from the doctor's part to our part to something could go wrong with the pregnancy because we're doing this test. Are there risks still involved in invasive testing?
Yeah, no, there's still a risk. I think just with the better ultrasound, the risk has gotten smaller, but there is a risk of miscarriage from either of those procedures. And I think that's why these days many people do the blood screening test and are satisfied that if that test comes back reassuring and the ultrasound looks good, they're not doing invasive testing.
This question's probably in Amy's wheelhouse, I'm sure in yours too, but definitely in yours. So when you get the results, and then parents are given this, or expectant mothers or whoever it is, are given this information, and they're left with something that could be really hard to digest and figure out, and they have decisions to make. What is the safety net for them through you guys? I mean, do you counsel people beyond the results and what it means and work with them, and are there places for them to go?
Yeah, I mean, when we give...
It's an emotional thing, I guess, is my point, right?
Yeah, and I think one of the things I love about being part of the GBMC team is that we have the ability to have multiple interactions with families who are going through getting a diagnosis, figuring out what this means, figuring it out, how it's going to affect their family, what it's going to mean for that child after delivery, and even make decisions about the pregnancy and how they're going to manage the pregnancy. You'll meet Dr. Kline and Marcia, but we can transition into with our pediatric geneticists very easily. We have weekly meetings where we talk about the patients that we're following and when they're delivering, and they can meet Dr. Kline before delivery. So we try to educate them. We try to provide emotional support. We try to be available for them. Sometimes it's hard. They don't have any other resource. Their OB can't always answer the questions that they need answered. And just helping them navigate through the whole process.
And in this day and age, do people say no to any form of genetic testing, even though it's recommended by you?
They're kind of like, I don't want to know.
Absolutely. And when families are referred to our office and meet with Marcia or myself, and they're sent for Down syndrome screening, the first thing I ask them is this something that you want? Is this something that you feel you need? Because there's always the option not to do screening. And I think our goal is to make sure whatever choices they're making they're informed and they're the right choice for them.
Can you talk about some of the, specifically, some of the syndromes, some of the diseases, some of whatever it is that you're testing? What are actual names of some of the things that you test positive for with a high percentage rate of
with a high
accuracy?
percentage rate, again, the chromosome abnormalities are more common, so the same things we screened for years
Such
ago,
as?
something like Down syndrome
Okay.
or trisomy 13 or 18. But I have to say, sort of one that's come up recently is spinal muscular atrophy, is a disorder where there's a very severe muscle weakness to the point that if you have the severe form, in the old days, a couple of years ago, you would die from the disorder in the first 2 years of life quite often. But it's been recommended that this disease be screened for in order to get better medical help and attention early, and also to know about it because it's such a severe disorder. Well, recently, just a few months ago, gene therapy came along, and so individuals diagnosed with this disorder are now getting treated in their first few months of life. So knowing about the diagnosis is very helpful to get immediate treatment and doing much better. So the screening can lead to better care down the road. It's just amazing. So that's what we always hope for with all of these diseases as they've come along. I remember cystic fibrosis was identified, the gene sort of in the 1990s, and we really hoped that we would have then very specific genetic treatments and for people to do a lot better with cystic fibrosis. And it slowly happened, but it depends a little bit
they
on
say they're
which
getting so
mutation
close,
you
right?
have. Right, so if you have this mutation, we've got a great medicine for you with cystic fibrosis. Oh, you have that kind of cystic fibrosis, okay, we can give you support, but we don't quite have the perfect medicine yet.
Because how wonderful would it be for you to be able to do this testing, find something, and then tell people, but there is a treatment, there
Right.
is plenty of hope, there is help. That's that's the trifecta, right? I mean, that's
Right, we
the
would love
ultimate.
to be able to do
Right.
that, and we can occasionally now in some cases, and in some cases, unfortunately, we can't, but at least we can give people information so that the expectant parents can be either prepared or make decisions about the pregnancy that helps them.
Is there a misconception about genetic testing that you run into often?
But, not necessarily.
Okay.
I think one of our goals that we're discussing every day is screening is not 100%, it's not diagnostic, it's not telling us anything definite. It's either indicating a low risk or a high risk. So I think that's sometimes where the misconception is.
I think we have a question from the audience, right? Or one or two?
Yeah, we have a question from Howard.
Given the increased incidence of autism in younger children these days, is there a set of tests that you would perform to help determine that before a child is born?
We don't have any testing or a testing panel that we do for that before a child is born, but hopefully you'll be here for the next half hour and we can talk a little bit about the autism testing that we can do once a child has come along. Yeah, I think I'll defer
There's
to
a lot of
the
research on
pediatric
it, but they just
expert on that
haven't
before
really
I
been
start.
able.
Yeah.
When you
Yeah.
look at this, or do you want to comment on that?
When we're talking about carrier screening, identifying parents who carry a genetic condition that they could pass on, one of the conditions on that panel is something called Fragile X syndrome, and probably in the population, about 1 in 450 women are carriers. And it's X-linked, so women can be unaffected carriers, but they could pass it on, and they pass it on to a son. He would have Fragile X, and individuals with Fragile X have intellectual disability, they have autism, and our carrier screening has included Fragile X over the last couple of years. So we're identifying women who are indeed at risk of having an affected child. Fragile X is not contributing to the increased incidence of autism, but it is one of the common genetic forms that we can check for.
Is there anything specific to this population in the Baltimore area where you find certain genetic issues crop up?
No, there really isn't. I mean, the Mennonite community, for example, that isn't too far away, they're known to have certain genetic conditions. The Ashkenazi Jewish population
Yes, I was thinking that, yes.
Will have a higher risk for certain conditions. But if you put all of Baltimore together, like a lot of the United States, it's such a
We run the
melting pot.
gamut.
Yeah, you got everything.
How about age of parents? How prevalent is that become? I mean, that's kind of one of the main reasons for people, I think, to get tested. Is that
right? That was, as Amy was saying, nowadays everybody is offered testing, but certainly traditionally we knew that as women get older that there's an increased risk for these extra chromosome abnormalities like Down syndrome or trisomy 13 or 18, very severe disorders. As you get older, you're more likely to have a child with one of those abnormalities, and so with one of those conditions.
Well,
and are we seeing older women all the time?
Yeah.
We have many patients over the age of 43 even having children.
Is there a baseline age when you, for a woman, mother-to-be, that you would urge her to do testing?
Again, we
Is it
offer
for-
testing to all comers, all ages. The traditional age in the United States is age 35, just arbitrarily. That's where the curve sort of takes off for these increased risk for the chromosome issues. But I always like to tell people, I went to an international conference, and in France it's age 38, so you can be younger for another 3 years.
The French, of course.
There we go.
Do you scoff at the idea of people who accuse people who are doing genetic research or genetic testing of trying to create the perfect human being, that they worry that will make decisions about having children based on what these tests say? You know where I'm going, right?
Right. There is no way to be perfect. We're all full of lots of mutations, and you can find one, and there is the ability now to actually use something that's called CRISPR technique, where you can actually chop a little piece of the gene out and fix it and put another gene in. But there's the one right down the road that's abnormal, so there's no way to, even though we seek perfection in all of ourselves, there's no way to do it genetically. Yeah.
Where are we going down the road? I mean, how fast is the technology moving, and is the science and the research moving? I mean, every month are you hearing something new, reading a new periodical? Every year we actually have a different test? I mean, how fast is this going?
In the prenatal world, the things that we can screen a pregnancy for has jumped dramatically even in the last couple of years. This new non-invasive prenatal screen that was really derived to screen for Down syndrome, and we've been doing it for about 6 years now. In the last year or two, now it's testing for even more chromosome conditions, or testing for things like dwarfism and other kinds of genetic diseases that we're not necessarily routinely using, but it is growing so quickly what we can test for that it's even overwhelming for us as clinicians to think, okay, who am I going to offer this test to? Should I be offering it? Is it a valid test? And in what circumstance is it appropriate?
We only have a few minutes left, and I think we want to get in another audience question.
Actually, we got 2 audience questions based on testing. The first one is, does this testing lead to more termination of pregnancies even if there is only a slight chance of development of abnormality found? And then the other question that's also testing based, but on a different subject matter, is, other than the BRCA gene, is there any other testing available for breast cancer?
I'll start with the second question. There's a lot of genes that have been implicated in breast cancer, and I think if you have worries about cancer, I would highly recommend seeing a genetic counselor who specializes in cancer. We have one at GBMC, and that person would help navigate which genes would be appropriate based on your personal history or family history of cancer. Your first question, I'm not necessarily sure if the rate of termination has changed, but one of the things that's very important is making sure families are educated between a definite diagnosis versus a high risk of a condition. So educating families, again, so that they can make informed decisions is very, very crucial and very, very important.
And people do terminate?
Yes, some people certainly do terminate their pregnancies, but I think we're able to give people, more and more information about conditions, expectations for what would life be like with an individual with this condition, and so people can make a good decision.
So it's not just the knowledge, it's what to do with the knowledge.
Right, to help them.
Yeah. It was fascinating.
Yes.
Thank you so much for being with Dr. Natalie Blagowidow and Amy Kimball. Just really interesting, and thank you so much for those great questions. It's a new world, right? And, so thanks.
We're now going to slip you out and slip 2 others in. So
You did a great job with the mic, by the way.
yes.
But we were
that moment.
Yes.
Right.
Little feedback. Yes, give them a big round. So that was, really we were talking about prenatal testing and, really diving into the unknown before you have a baby and then what to do with that information while you're pregnant.
What we're about to talk about is something that surprised me is even done, is parents, we did so much pre-birth.
Right.
And then the testing afterwards was to get your kid into a good school or something.
Right. I mean, there's so much testing that can be done for children and teenagers and adults, as someone just asked about the breast cancer gene. So genetics has come a long way, and joining us to talk about that now with older children is Dr. Antonie Kline, who is the Director of Pediatric Genetics at the Harvey Institute of Human Genetics, board certified in pediatrics, clinical genetics, molecular genetics, and cytogenetics. Is that correct? And Marcia, right, Ferguson, who is also a genetic counselor. We have the genetic counselors here too because you're often the ones who work, you do the research, give the diagnosis, do the testing, and you're often then kind of working with the families or the individual too at the same time. So it's a really nice partnership for the people who are with you, for your clients or your patients. So thanks for being with us.
Thanks for having us. Thank you.
And how recent is this type of genetic testing, postnatal as we called it before? Because it surprised both of us, and it must be surprising to others.
So genetics has been around at least since the early 1900s, and pediatric genetics evolved because many conditions were present in children. So it's actually a well-established field. Interestingly, not just pediatric geneticists, but there's also internal medicine geneticists for when people are adults.
So let's just talk about the reasons that someone would be tested, or parents may make the decision to have their children tested, or they may get tested themselves. What are some of the reasons for doing that?
So actually, most of the referrals are for complete evaluations, and there's not always testing that we offer, but what happens is a baby is referred possibly for a birth defect or something unusual about how the behavior of the baby, how the behavior is. And then older children can be referred for the same thing, a minor finding on exam, or developmental delay, or behavioral issues such as autism. And the pediatrician wants to find out, can we provide information to help with the recommendations and the care for the child, and possibly testing that could pinpoint the cause.
Okay, you mentioned autism, but what are the other things that pop up that would get a postnatal?
So specifically for behavior?
I guess. I mean, just what are they? There's autism and...
So there's...
Sometimes you don't know.
There's
it's
self-injury. Some patients injure themselves. There can be depression or anxiety accompanying, say, developmental delay, and that could even indicate an underlying syndrome. Development is huge. People have...
So I have lots of questions about that, because I didn't realize that for developmental delay that there is testing available that would give you valuable information. And how does that testing, does that include a blood test, an MRI? How do you go in and, if I brought a child in who has a speech delay, let's say they haven't said a word and they're 4 years old, and you're trying to figure out what's going on, how would you evaluate that child from your expertise?
So typically, we will be referred a patient if there's maybe more than one thing going on, and the pediatrician might want our input. So maybe just speech delay by itself, we might not see those patients. But if the pediatrician notices that the child's hair hasn't grown, or there's a birthmark, or the child's known to have a heart defect, then they would ask us, how can you tie these things together? Is there an underlying condition, and could you offer testing for something? So it's always a stepwise, slightly lengthy process.
The first symptoms you mentioned to me all sounded like psychologically based, but then you mentioned
neurologically too.
Okay.
Yeah.
To me, that might be one and the same thing, but there are other physical things that bring you in.
Yes, definitely.
I could say a little
Yeah.
bit. So when we're talking about young children, I think oftentimes they may get referred, as Dr. Kline said, because there could be an unusual feature, an unusual finding, something physical like their facial features don't match the family's that well. Maybe their chin the child's chin is very small, or their ears might be a little bit different, small or something like that. Sometimes growth could be affected. They may be larger than you'd expect for their age group, or they may be smaller, as well as developmental issues.
And what could that signify, those traits you just mentioned?
So there could be an underlying syndrome. So the child could have a genetic or a chromosomal syndrome going on, something that would tie the different things together. And so we, would evaluate them and then would consider whether testing might help us to identify their potential condition. And you would, mention the testing. And so if we were going to go down the road of genetic testing, we would often start with this test called a microarray. And it's a way to really assess the chromosomes to see if there are differences in the amount of chromosomal material, sort of on a finer scale.
So that's a blood test?
It's blood, but it also can be done through saliva,
Okay.
through a cheek swab, something like that, which is nice for young children to not have to put them through the blood draw. So that's sort of a starting level of testing to sort of screen for changes in the chromosomes. And in other cases, we may suspect a specific condition, and then we may just target that particular gene and test
Would
just
you
one gene.
Would you do DNA testing at this point? Because, okay.
Yeah.
It's so interesting because prenatal is so before, and you're almost like solving a mystery. So you have a child or you have a teenager that's presenting a certain way, and everyone's trying to figure out the piece of the puzzles that can form with what is happening, which would help with treatment and so forth. Is this what you're doing? I would imagine this is growing by leaps and bounds, this type of area of expertise.
So there are over 10,000 syndromes and probably more identified regularly. So in a sense, it's growing with new discoveries. Also, newer genes are being identified, and we have more in our armamentarium. But I think that physicians are fairly comfortable now referring to genetics to be the mystery solvers, as you say.
But new genes are being discovered?
So we know that there's about 20,000 genes, and they were identified when the human genome was finished. But the thing is that it wasn't quite finished, and areas that they thought maybe were 3 genes that they hadn't identified have ended up maybe being one large gene, or vice versa. And so there's an even newer test than the microarray that's helping to pinpoint newer genes.
How often do you have a parent who will come in with a child based on maybe a recommendation by their pediatrician, and they're trying to find something, and you run the testings and you just can't find anything? Like it just was inconclusive, or how often does that happen?
So I would say that happens probably at least 25% of the time. There's probably, even if we do specific DNA testing for conditions and they are negative, there's probably hidden changes not in the genes, which are only 1% of the whole genome, but in the other 99% that we're just only now starting to be able to investigate.
The other thing that
At least you've ruled out something, though. Right.
I think the other thing that happens is that we may see a child over time, and we may not determine what their diagnosis is in the first, several visits, but then as they mature and grow, we begin to get other clues and other pieces of information, and testing improves, and so then we may arrive at a diagnosis, several years into seeing them.
Do you also delve into family history on the parents' part?
We do, and that's one of the important roles of the genetic counselor, is to take a 3-generation pedigree, so drawing out a family tree, and we're looking for clues. Are there other family members who have any of these symptoms or features, and also just looking for other genetic conditions in the family that we can give the family information about.
And 3 generations, will be back to grandparents or great-grandparents?
Grandparents.
Okay.
We have a question from the audience?
Yes, we do. The question is, the example of birthmark and speech delay was brought up. What is this association? Is there a syndrome?
So there's many types of birthmarks. There are probably, I can think of 10 or 15 conditions that might have a slightly dark form of a flat birthmark. There's probably 5 conditions that can have a pale form of a birthmark, and birthmarks together with speech delay or other developmental delay probably very, very common. So again, getting the family history, getting the medical history from the child, doing a careful physical exam. Every involvement with us includes a very detailed physical exam where we make measurements of the whole body and compare them to charts, and then trying to figure out, is there a specific condition or conditions that
See,
could fit?
you're referring to birthmarks, surface birthmarks.
Right.
Pardon my lack of knowledge, but it's just a birthmark, right?
Sure. I mean, most people in the world have a single birthmark. It's more, are they significant when paired with some other finding?
Huh.
How about for the parent of a child or a teenager who already has been diagnosed with a condition, already has something that they've been working on, but then wants to delve into, was it genetic? Does that make sense? So let's say they have autism, and they've already been diagnosed with autism, but now they wonder, the parents wonder, well, am I carrying something? Is there something abnormal about our genetics? Should I have another child? That kind of thing. Are people coming at it from that perspective as well?
Sure. Often one of the questions is, could this happen again with my future children? So we often see families where that's the situation. And then even though autism itself has been diagnosed, that's a broad term.
Yes.
And then we might recommend specific testing, like Amy said, Fragile X testing, or Marcia said, Microarray, etc.
Do you also tell, let's say, a teenager that they have something that they may have gotten from their grandparents, so their having children in the future could also be affected?
Sure, we do. If we do make a diagnosis in a teenager or an older child, we do sort of casually mention, when you're thinking of having children, you could pass this on. And depending on the age of the child, we
Yeah,
don't
that's
go
a heavy-
into it anymore.
Yeah.
It's pretty heavy.
And some counseling goes with that, I hope. But
Sure.
I mean, you must counsel them before they get genetically tested, I would imagine, in many cases, to really determine if this is some information they want at this point.
Yes, definitely. Some families, I think, are hesitant to have a genetic diagnosis, for all of these reasons. But I do think for many families who've been dealing with their child having delays or issues for many years, they often want a diagnosis because they want to know, is there a chance, for more children? Is there a chance for other people in their family? What does this mean for their child? Can we help manage their child better if we have more information? So,
do families sort of push you for a diagnosis when you're not really certain? They want
Yes,
to have a label.
yes, I do think that it can be very disappointing for families when there isn't a diagnosis, when they suspect there is something going on and it just isn't clear what it is. It can be a frustrating experience.
We also always tell families that all of us in genetics are constantly going to meetings to hear about the new developments, and we have contacts in the field. So we urge them to keep in touch with us and have follow-up annually or every other year, because new things are written about, and then it might apply to one of our patients.
I just remember in the past where hypertension was first talked about, then it was ADHD, and then there were other things tossed onto it. And a lot of those children go on to be diagnosed with other things, including autism. And I don't know where I was going with that. It was just a comment.
One thing, I used to work with the Huntington's Disease Society, and one of the earliest, I think, tests that were available was for Huntington's, which is a devastating, completely genetic disease, right? And I think, I talked with a lot of people who struggled because I think the carrier has a 50-50 chance of passing it on. So the children never, they had to decide, do I want to know, do I not want to know? I know what my fate is because I saw one of my parents go through it. So you must run into, maybe not that extreme, but that's a pretty big thing. That's a pivotal moment to do the testing. It's a pivotal moment to read the results.
Right, absolutely. And actually, specifically for Huntington, it's so significant in every way that we always refer to a Huntington clinic, such as at Hopkins or Maryland, because they have they have psychology, they have social work, they have everything built in for that. But for our patients, if there's a pre-symptomatic condition that one of the parents carries, for example, generally we don't recommend testing people under 18 because we want them to make that decision. And sometimes we will get families who push and want a diagnosis even when it's not relevant for the child until they're an adult.
Or sometimes the general practitioner, the pediatrician, or the internal medicine doctor will run those genetic tests, which, you know, we think it's just so important for the patients to have the proper counseling and make an informed choice. And sometimes we get those phone calls, you know, would you see this patient? We just did a test on them and they have something.
So they need to go further. They want
Yeah.
you to kind of, because that's where you shine. I mean,
Right.
are there certain conditions that you're just waiting to get a genetic test for? I mean, you're just hoping that that will come through. I mean, are there certain things, are we on the brink of learning more about that come to your mind?
So probably autism is one of those, because we do have a sort of standard group of recommended tests that we'll go through, and if certain ones are negative, we'll go to the next step. But there's a high percentage where families don't find out about that, and because it's so common, it would be really amazing to know. When I was in training, there wasn't much known about hearing loss, for example, and now there's a big panel, and we can often identify the cause and help families with that. So that's another pretty common thing that has come a long way.
I don't know how long ago you were in training, but autism,
A long time.
autism seems to be booming.
Everywhere. It is.
And everybody's thinking it's just the fact that we now can diagnose it. Is that your feeling?
Yes, I think the diagnosis is very clear with the criteria, and there is, I think, a higher incidence than quite a bit.
It can't be just diagnosis.
Yeah.
Yeah, there's too many.
But there are multiple causes, and certainly the thing with immunizations was put to rest, although not everyone still
Believes it, yes.
But isn't that part of the problem? And I hate to just focus on autism, but because it's such a wide, broad spectrum, that there'll be no one test for autism, right?
Sure.
There may be multiple, and still may not be. I mean, it's so Fragile X really is the only part of that spectrum that you can definitively test for, right?
Well, but we do recommend the microarray. There can be a tiny deletion on one of the chromosomes or a duplication that is known to be associated with autism.
So are you surprised that more people don't come for testing? Because I happen to be in this autism world, that's why, and there are very few people I know who have done it.
So again, most pediatricians and other specialists will tend to refer to us if there's more than one thing going on. Although I think autism, there is a pretty standard set of recommendations. So I think we tend to see the ones that have a birth defect or something else.
At this point, is there any condition that you can identify through genetic testing and turn around or end?
So more and more there are conditions that have treatment. When we go to meetings, there's always a new couple conditions that actually have treatment, and all the researchers who are working on each one of those conditions are looking for treatments in the animal models, and if those are successful, then it can move into human trials, and there actually are treatments now.
Do you find that there's a sense of relief when somebody finally figures out, through genetic testing, if they figure out what is going on with them or their child?
Yes, we certainly have seen families who have had a long voyage with their child with multiple issues, and time again, testing has been negative, and finally they get a diagnosis, and you know that it's not, the parent knows it's not their fault, and also we can help predict what is going to be needed as they move forward. As Marcia said earlier, I think there can be a huge relief.
I'm trying to refer to my emails, but I'll just ask you the question. It seems like a couple days ago we got an email from you, and you wanted to talk about a specific, is it research that you're doing now, or something that you've seen with increasing frequency?
So I've worked since my training with a condition called Cornelia Delange syndrome.
I'm glad you said it.
Yes. Say it again.
Cornelia Delange syndrome. It was named after a Dutch pediatrician who published it in 1933. And it's a very rare condition, but I've worked on it my whole career, and we have clinics at GBMC twice a year, and we get referred patients with it. And I love
From
working
around the
with
world,
it.
I would
From
imagine.
around, well, certainly around the United States, but I've traveled worldwide to see patients with this.
And what is it?
So it's a rare condition. It's generally of small stature, so they're proportionately smaller than average, often with intellectual disability or learning disabilities, often with behavioral problems, and then various abnormalities physically, such as missing forearms, missing digits, heart defects, cleft palate. There's a whole range of how people can present.
You say stunted growth. Are we talking dwarfism or
So dwarfism tends to be disproportionate, where maybe the arms and legs are shorter and the body and head are normal, and vice versa. Proportionate small stature is just tiny people that with the right proportions.
And how was it discovered, the syndrome?
So-
Obviously, the person's name.
Yeah, so she wrote about, she was the first person to put two unrelated patients together in an article, and then over the years more case reports were written, and people just came to appreciate it.
We have a question from the audience.
All right.
Just flipping the script a little bit, are tendencies towards social diseases like alcoholism and drug addiction indicated in any DNA
Great
tests
question.
or testing? Sorry.
Not that I'm aware of, or certainly not that we use in a clinical setting.
They do say it runs in families, though.
Yeah, I guess we would say we can see those things in families even several generations back, and there's a few conditions that can present that include alcoholism, but it's what we would call more of a multifactorial condition where genetics plays a role and probably environment plays a role, and similarly with other conditions like that.
What would those few conditions be that you mentioned?
In addition to...
Well, you said it shows up in a few conditions besides alcoholism.
Oh, so Tourette syndrome is a condition that most people have heard of, where there can be verbal or motor tics, so people can say things spontaneously and not intend to, or they have movements of their body or blinking and other things. And in those families, we see a higher incidence, for example, of alcoholism and also obsessive compulsive disorder. So that's the one I was thinking
Okay.
of.
Are genetics fixed? In other words, once you test for something, your genes don't change. You can't do anything to change the course of whatever's set in your map or whatever.
Right, that's an interesting question. So yes, your genetics are set at conception, and the genes don't change or mutate once you're conceived. But between parent and child, there's many mutations that can be acquired on the way or through things that occur right at conception. Would you agree?
Yeah, I would agree. I mean, there can be post-conception changes, but they tend to affect just a subset of the cells of the body. So a person could be mosaic and be mixed for having a change in some cells, but not all cells.
What affects us more, genetics or the environment?
Genetics.
Good, that takes a load off my parenting.
Is there anything you've been
It's not my fault.
dying to bring up that we haven't elicited from you at this point? The one question you've been dying for us to say.
Well, I just thought this was something we want to share. So we have followed a patient that we finally figured out what this patient had through whole exome testing. And it was a gene that hadn't really been known before, what the function of the gene was. And through whole exome testing and then this sort of almost worldwide sharing of data where different physicians can look and find other physicians who found a patient with a change in the same gene, and we discovered the diagnosis for this patient, and the condition is named after Dr. Kline.
Well, very good.
That's really cool. I mean, I hate
That's amazing. Is what it
And
is.
more and more patients are being discovered all the time.
What's the name of the condition?
Kline syndrome.
How does that feel?
So it was pretty exciting. I never thought I'd have a condition named after me. And actually, I got an email this morning of another patient in Europe who they suspect, and the testing has shown it.
Again, the syndrome is?
So it's AU-Kline, K-L-I-N-E. And it was really because we wrote the first article with our colleagues from Canada and myself, and Dr. O was the first author and I was the last author.
That's very
in
exciting.
the catalog.
The symptoms are?
So there's
You don't have it.
You never know.
So growth tends not to be affected. Intellectual disability is on the more severe side, and there can be specific facial features. There can be problems with the kidney and the renal system, and scoliosis, and some possibly there's some sort of a long list of conditions, but it's
So the fact that there's more genetic testing is telling us more than just for that one person. It allows you to compare other people and bring it all together. Is that correct?
yes, in a sense.
So it's a good thing that
And so
more
for-
people are getting genetic testing.
Right. So, for example, from this family, the mother has been able to connect with the Canadian family and other families that are now trickling in, and they formed a little group, and we're going to have a meeting of all the families in the coming summer at GBMC.
Very good.
That's really cool. I'm surprised you're not traveling all over talking about it, but I'm glad you're here. I think we have another question,
Audience
right? I want to
question.
make sure we get to that.
Sure. Earlier in your discussion, birthmarks came up. So the question from the audience member is, would a pediatrician likely know to point out an unusual birthmark that could be linked to a genetic condition? Or is this something that parents typically identify themselves?
So I would say most parents notice if their children have birthmarks or a single birthmark. We would expect the pediatrician, if there were a number of birthmarks, we would expect the pediatrician to think that it could be possibly due to an underlying condition and bring it up to the family. And many people have 2 or 3 birthmarks. Often we'll find a parent and a child have a birthmark in the same spot on their body, which is interesting. But I think if they're concerned about an underlying condition, the pediatrician would.
And it wouldn't be just the
Bring that up.
birthmark. There'd have to be other things going on. It's not like you have a kid with a
And
birthmark.
It's usually not a single birthmark, it's usually a constellation of
Okay, a lot of birthmarks.
Up until today, I thought birthmarks were just,
Can I get to this one question? I feel bad if we don't, in case Ruth is watching.
Okay.
So Ruth wrote this question, and she mentioned something that I'm not going to know how to pronounce it, so you can correct me. Would you please advise me of any new breakthroughs, such as medications or procedures for relief of gynecomastia
So
in young boys?
So gynecomastia is enlargement of the breast, especially in males because they don't typically have breasts. And it's fairly common in the general population. One or both breasts of males can be larger in some people. There is a specific genetic condition, Klinefelter Syndrome, which is an extra X chromosome. So there's 3 sex chromosomes instead of 2. And Klinefelter Syndrome can have gynecomastia with it. In terms of management for it, I'm not aware of specific medication, but sometimes surgery can be done to reduce it.
Yeah, and she goes on to ask, and I'm not sure this would be your area, but does the consumption of soy milk have any bearing on its development, and or other foods contributors? So this would be, you would need an expert on that particular condition.
Well, estrogen can increase breast development
Right.
in males. For example, if they take estrogen for prostate cancer, I think that's a possible side effect.
But is this a condition, or would this be a symptom that you might have genetic testing for?
If we suspected Klinefelter syndrome, we would do genetic
Okay.
testing. I think soy has some natural estrogens in it,
It
so
does.
that's probably why she was
Yeah.
asked.
and this
Yeah.
would just be a cosmetic problem
Yes,
anyway.
absolutely.
It's nothing you have
And
to fix.
right.
Another audience question.
Hi, my name is Laura. I have a question going back to the birthmarks. I'm very curious about this.
Okay.
My daughter has 2 strawberry hemangiomas. Is that also considered a birthmark, or do we know anything about hemangiomas or relating to any sort of illnesses?
So hemangiomas are a collection of blood vessels under the skin, and they tend to be raised. Many people, again, have 1 or sometimes 2, and there are genetic conditions that can go along with an increase in hemangiomas. But again, I would expect there to be other findings in the child possibly development issues or more neurologic issues to indicate an underlying syndrome.
Interesting. Very interesting.
Yeah, thank you, and thank you for all your questions. A lot of interest in the birthmarks today.
Well, yeah, like me, I think.
Because I think that affects everyone, right, pretty much? So people are, thinking.
And everybody just assumed it was.
Right.
Mark
And do you know
on
how
your
many,
skin.
how many people have, like, maybe a child with some sort of issue, and they're like, well, they have a birthmark, and that's going to be the thing that's going to get them to call you, but
Yeah, you can get
you
lots
can
of
walk them
telephone
through
calls.
all of that. Well, I think that's all the time we have, and thank you so much. It's really been so interesting talking about genetics.
And I should preview that next month, January, is Cervical Cancer Month, and we will be doing a program on it. It will actually start with 2 Year Health at 12:30 on Facebook Live, and then what we call ourselves
Greater living.
Greater living.
Because
We'll-
we are
we'll
living a
continue.
greater life just
I
by
like to
being
call it
here.
the guide to greater living, but I'm not sure we're guiding. But anyway, that will be January 10th again, 12:30, and then we're on at 1, and we hope to see you then.
All right. Dr. Tony Kline of Kline Syndrome, right? And Marcia Ferguson, thank you so much.
Thank you for
Thank you. Woo.